Welcome to Nourish MD, Doctor Dietitian Dialogues, where doctors and dietitians empower you about your health and discuss and provide a better path to health and wellness. Proudly presented by Concierge Medical Practice Private Physicians Medical Associates, PPMA, with your hosts, registered dietitians and nutritionist, Lauren Papanos and Romana Brennan.
Hello, everyone, and welcome to the Nourish MD's podcast. I'm one of your hosts, Lauren Papanos. I'm joined by my co-host, Romana Brennan today, and we are diving into women's health. We are going to be doing a part 1 and part 2 to our episodes because this is a topic that we both specialize in and have a lot to say. And so today we're going to be diving into the relationship between perimenopause and menopause and metabolic health, and really diving into how the hormonal changes that occur during these timeframes, both peri and postmenopausally, affect our metabolic health and affect metabolism, blood sugar control, cholesterol, all these things that you might have questions on. You might be wondering, why are these blood sugar and cholesterol markers getting higher as I get older? We're going to explain all of that today. And then part 2, we'll be diving into a little bit more as it relates to some practical strategies for symptom management and other solutions that you can explore as it relates to this topic. So let's just start off by kind of catching up on what Dr. Masterman discussed in our first episode on this. If you haven't had a chance to listen to that, it's a really great interview with Dr. Masterman. He's no longer a practicing physician, but he is a professor. And so he teaches a lot about this subject, is a former OBGYN, and he provides in the episode some resources for where to find a practicing physician that may be able to support you in these areas. But we talk about that episode, what essentially defines menopause. And so as it relates to menopause, really what we're looking at is that it's been at least 365 days or 1 year since you have had any period. So bleeding, a menstrual cycle. It doesn't necessarily need to be an ovulatory menstrual cycle, but that there's been a, couple day long bleed like we would, think about for a period. So it's been 12 months. There's also some lab markers that he mentions, like FSH, that can be looked at, and LH that can be assessed to understand if someone is postmenopausal. Prior to that menopausal time period, though, we call that time perimenopause, and that's a few year long transition. Some of the research shows this could be anywhere up to like 10 years, but it could be as short as maybe even 2 years. And that's really when your body's going from this transition of being in your reproductive hormonal function to being postmenopausal. So during that time, we see a lot of shifts happening hormonally in the body, which we're going to talk about here in a second, of what to expect if you are in that transition time period, and then what that might look like once you've had that last period and what to expect. So a lot of hormonal differences between when you are in your reproductive years, when you are going to that transition of perimenopause, and then when you are postmenopausal. And when you're postmenopausal, that's when the body's in a very low hormone state. There's not a lot of fluctuations happening, just a lot of suppression of sex hormone production. And that's generally why you're, not having a period for a year and then not going to have any future periods. So Romana, maybe you can just introduce us to some of the hormonal changes that we expect to see both during this perimenopause and then this postmenopausal time period.
So when we are discussing this time frame, we're really thinking about what is progesterone doing, what is estrogen doing. These are the two hormones that, at least for women, we really focus on first and foremost. Of course, we do have our androgens, for example, testosterone, DHEA. Even though those are more characteristically male hormones, they're still very important in females as well. So kind of shifting the focus to more progesterone, estrogen. This time frame of perimenopause is really marked by a stark decrease in progesterone and a fluctuation in estrogen. So usually when we see this cyclic nature of symptoms, whether that's hot flashes, night sweats, things of that sort, insomnia, usually those different types of symptoms are coming about because progesterone is steadily decreasing and estrogen is fluctuating. So we might have these valleys where estrogen and progesterone are low. We might have these peaks where there's a really big discrepancy between that lowering progesterone and that estrogen. And when estrogen is unopposed, that's when we really start to see more of these types of challenges, more of these high estrogen symptoms. So that progesterone normally, when we are in our reproductive years, that progesterone is steadily increasing after that ovulatory phase. During the second half of the cycle, the luteal phase, that's when progesterone is increasing. That's when it becomes more important. And then it comes back down before we have a period. So of course, as those periods, those menstrual cycles become fewer and far between, so you're skipping a month, maybe they're coming every 3 months, a couple times a year, that progesterone tends to decrease consistently. Maybe you still are having some progesterone production, but all in all, there's not a real trend because we're not having that typical follicular phase, ovulation phase, luteal phase, where progesterone really is the star during that luteal phase. Versus estrogen does fluctuate naturally a little bit more throughout the menstrual cycle. Now within this perimenopausal phase, it's really going up and down, up and down, up and down. So again, especially when it's unopposed, estrogen versus progesterone, and that ratio is off because progesterone's steadily decreasing, estrogen fluctuating. That's why we might see that fluctuation in symptoms. So again, the symptom exacerbation is usually when you're in those times of higher estrogen compared to that low progesterone. Lauren, why don't you talk to us more about what those androgens are doing? For example, the testosterone, the DHEA.
Yeah. And just to be clear, as everything you mentioned with the estrogen progesterone is what we would expect during perimenopause. In menopause, you would expect to see low levels of progesterone and estrogen. So for anyone that's listening, there are differences, right, in those hormones. So everything that you just talked about is like what you would expect before it's been a year since that last period, right? And then after it's been a year, then we would just see low levels of everything. So low progesterone, low estrogen. So just want to make sure that we mention that so that it's clear to anyone that's listening what to expect. But yeah, as it relates to testosterone and androgens, testosterone comes in part from the ovaries, but we also have some testosterone that's made by the adrenal glands. And then there's other androgens. Androgens is like a class of hormones. Testosterone is one of those subhormones under that class. But there's other androgens like DHEA, DHEAS, androstenedione, that are made primarily from the adrenal glands. About 80% comes from the adrenals, so a much larger percentage than testosterone. And when you go through menopause, your adrenals don't shut down function, but your ovaries do, right? And so we actually see that there's a lot more responsibility, if you will, on the adrenal glands, which are these two little glands on top of your kidneys, for hormone production. And it's one of the reasons why when you're going through perimenopause, you're dealing with a lot of stress and a lot of adrenal dysregulation, you're going to have more problems with these menopausal symptoms because now the adrenal glands have all the work to do on sex hormone production. And we'll talk about in our next episode some ways that we can really support those adrenal glands to help with this. But generally, once you go through menopause, your testosterone production does start to decrease. And that's because most of it is coming from the ovaries. However, the amount of androgens that are coming from the adrenal glands really is unchanged. However, a lot of women do experience issues with hirsutism and these high androgenic symptoms. So things like peach fuzz or dark coarse facial hair growth, whiskers on the face, hair loss on the head, really oily skin. Sometimes people even get like menopausal acne. And that's because the sex hormone binding globulin, which is a binding protein that comes from the liver that helps to be able to regulate how much bioavailable testosterone is in circulation, starts dropping. So we're not necessarily seeing that we're making more testosterone during this time period. It's just that there's more available for our cells. And that's because the SHBG is dropping. Now, this is also something that similarly happens when someone has a condition called polycystic ovary syndrome or PCOS. So if you were diagnosed with that at a young age when you were in your reproductive years, then you could experience maybe some of the similar symptoms that you experienced when you were in your younger years, because it's a similar hormonal profile shift that happens. If you do have PCOS that's unmanaged when you go through menopause, then you might even have higher androgenic levels. You might have higher testosterone, higher DHEA to begin with. And so you might be more susceptible to experiencing these symptoms like the dark coarse facial hair growth, the hair loss on your head and such, because you've got high androgens, so high levels of testosterone and DHEA, and you've got low levels of sex hormone binding globulin to bind up those androgens. So it's really important for when we're talking about androgens to really look at the SHBG piece of things, what your previous history is hormonally, and then also adrenal function because androgens are made primarily in the adrenal glands.
Discover the wellness you deserve. At Private Physicians Medical Associates, PPMA, you'll receive personalized premium preventive care and one-on-one medical attention with an emphasis on prevention, nutrition, and wellness. Extended office visits, appointment availability, 24/7 physician access, limited patient enrollment, PPO insurance and Medicare accepted. This is concierge medicine. This is medicine the way it should be. Call today for a free consultation at 949-566-8179.
So we talked a little bit at the beginning about the role of FSH and how that can be one of the criteria for understanding that someone's in menopause. Romana, what are some other things that we need to understand about these FSH changes?
As estrogen decreases at this consistent level, again, with some fluctuations during that perimenopausal timeframe, but especially once you've kind of reached this menopausal period, again, 12 months or 365 days without a menstrual cycle. At that point in time, with those estrogen levels being low, essentially FSH, again, is unopposed. So similar to how we were talking about progesterone and estrogen having this like oppositional relationship, with FSH and estrogen, there's that same kind of antagonism. So with a lot of these hormones, they work on a negative feedback loop. So FSH is not an adrenal hormone, not an ovarian hormone. It actually comes from the pituitary gland in the brain. What happens with estrogen is as estrogen levels are increasing, that has a negative feedback loop on FSH, which actually decreases FSH. But when our estrogen levels decrease, we don't necessarily have that signal telling the brain, telling the pituitary gland to decrease that FSH production. So that's how that signaling happens, and how there actually is not that signal telling us to kind of monitor that FSH level. So once you get to an FSH above about 25, that is when we have identified that that's kind of that menopausal range, any FSH levels above 25. So as Dr. Masserman was explaining, that's a good marker of how close you are during perimenopause. Again, it will fluctuate still during perimenopause because you're going from those times of higher estrogen to lower estrogen. But then especially if you're going on that 12-month mark, you can certainly get your FSH levels checked and see, okay, if your levels are above 25, it's very possible that you're not going to get that period menopause again before that 12-month mark. So just another way, another piece of data that we can have to kind of assess if you are officially in menopause, aside from just that calendar type of method and determining if you are 365 days since your last period. I appreciate that you mentioned the thing about adrenal glands, adrenal function, adrenal production of these hormones, as opposed to ovarian production. And I think just as an aside, it can be helpful for individuals who've had a hysterectomy or ovary removal, just to kind of conceptualize sort of what's happening, and to also help determine, okay, maybe you've had your ovaries removed, but you're still getting some of that production from the adrenal glands for things like androgens. But why don't we transition to more of a nutrition conversation and talking about how these changes in estrogen really affect cholesterol levels, blood sugar levels. During that menopausal time frame, we often see, individuals saying, my cholesterol levels are increasing, and we'll discuss a little bit more about why that happens. Also, individuals noting that it feels harder to control their blood sugar levels, or just not quite sure why sometimes the lab markers are changing, even though some of maybe their dietary patterns haven't changed. So let's dive into that. And Lauren, why don't you start us off with that blood sugar conversation?
Yeah. And I don't think a lot of times the connection is ever made, because a lot of times patients aren't even told that, this is a normal, progression that we see as these hormone levels shut off. And I think a lot of times we just think it's because we're getting older, as opposed to, well, why is this change happening as we're getting older, right? What is the driver of aging that's causing this to occur? And we see it similarly in men. Men go through what we call andropause, where it's similar to menopause, where they start to make less of those androgenic hormones hormones like testosterone. So this isn't just reserved for women, but it's a big piece of the nutrition conversation, because if there is blood sugar dysregulation happening, so if someone has a high A1C and has a high fasting blood glucose, then we know that that person is likely in an insulin resistant state. Insulin is the counter-regulatory hormone that comes from our pancreas that helps to be able to get sugar out of the bloodstream and into the cells like our muscle and liver cells that use that sugar. And so when we're insulin resistant, essentially our body is producing that hormone, but it's not working as effectively. It's not getting that sugar out and into the cells. So there's like this blockage that's happening, if you will. And we know that insulin resistance is one of the biggest drivers for weight gain and for diabetes. That's actually what predisposes diabetes to develop. And if you're experiencing weight gain, then really you're not going to get very far without lowering insulin, because insulin is the hormone that drives fat cell growth. And so if you're seeing weight gain happen, it's because you're not necessarily making more fat cells, just the fat cells that you have are continuing to grow. And that's because insulin is a very big growth hormone that causes that growth process. And this can be driven through estrogen. Thyroid hormones also impact this, and our thyroid hormones are heavily impacted by progesterone, and both estrogen and progesterone drop when you go through menopause. So sometimes we'll start to see blood sugar issues present in perimenopause because that progesterone is low, and that's impacting thyroid hormones that are then impacting blood sugar metabolism. So it's all connected there through progesterone to thyroid to blood sugar. And then definitely once a woman goes through menopause, we see more issues here, because now you've got also low estrogen, and estrogen also helps with blood sugar metabolism. And this can occur even before menopause if you're just in a low estrogen state, which sometimes women are. So it's something for us to really look at as part of why there's blood sugar issues going on. And although maybe you don't want to do hormone replacement therapy, you don't want to use estrogen and progesterone to help with this, that's okay. But by knowing where you are in perimenopause or menopause, it helps us understand what is the hormonal environment your body's in and why you might be in more of this high blood sugar state, and how your body's physiological changes can affect how we prescribe nutritional interventions. Because, maybe what we'd recommend for you isn't the same for what we'd recommend for a 25-year-old who has really healthy, high levels of estrogen and progesterone, because they're still in their reproductive years, right? So it doesn't make sense to be on the same type of nutritional setup when you're 25 versus when you're 55, because the hormonal environment of what's helping regulate metabolism is entirely different, and we have to take that into account. Outside of blood sugar, like you mentioned, we also see a change in cholesterol metabolism occur. And a lot of times this can be alarming to people. What are some of the reasons as to why this happens?
Yeah, so we do actually have estrogen receptors in our liver. When we're talking about triglycerides, LDL cholesterol, total cholesterol, those are the labs that we usually see affected. Research has actually shown that average increase in cholesterol can actually be upwards of 10 to 15%. And that's for total cholesterol, which can be very significant and certainly can be alarming if that increase has happened over the course of a couple of years, or even shorter period of time than that. I think we've said it in a previous episode. Cholesterol numbers, only about 30% of that is actually reflective of dietary cholesterol. So the liver is really key in cholesterol production, cholesterol recirculation, even genetic factors that might predispose you to having higher cholesterol levels. So the cholesterol conversation is more complex than just what's your total cholesterol number, or if you have high LDL or low HDL, things of that sort. So it also gets a bit more complicated during menopause, right? Because our estrogen receptors that exist in the liver are really key in helping regulate this metabolism, cholesterol production. So when estrogen levels decrease, those receptors somewhat change, right? And so that's why we're seeing, especially driven from liver function, that those cholesterol levels are changing, which from a dietary perspective, from a supplement perspective, even from a lifestyle perspective, we can make positive shifts in helping correct this increase. There's more than just LDL and HDL. And that's where something like the Cleveland Heart Lab that we work with, where you can actually get the particle size information for those cholesterol levels, is going to be really helpful. We can take a deeper dive into beyond LDL and HDL, more information to get a better assessment of your cardiovascular risk. And beyond just those cholesterol levels, also part of that lipid panel are your triglyceride levels. You might see those as TG on your labs. Triglycerides are very dependent on your blood sugar balance. So similar to how you're chatting about blood sugar balance, insulin resistance, we really want to hone in on that and correct that, especially if your triglyceride levels are elevated, which again, naturally, that tends to increase with menopause, but there's a lot that we can do to help combat this and correct this, again, from nutrition, lifestyle, supplementation perspective.
Yeah, and I just want to underscore that, as you mentioned, the solution doesn't lie in lowering cholesterol from your dietary intake, because that is only going to influence this by about 30%, right? So there's still a lot we can do within diet and supplementation, but it's not through reducing cholesterol food intake. It's through working on improving liver function so that we can then reduce or improve, I suppose, cholesterol metabolism, right?
Exactly. Yeah. And also, like I had mentioned with the liver in charge of cholesterol recirculation, sometimes it's completely irrelevant to the cholesterol. Most times it's completely irrelevant to the cholesterol that you're intaking. But how much of that cholesterol are you recirculating? Are you having a diet that is full of fiber or completely devoid of fiber that can actually help bind those cholesterols and eliminate them through your stool? So again, there's a lot more nuance to this conversation than just stop eating eggs.
Yeah, and we'll chat more about some of these strategies in our follow-up episode to this. But before we do dive into that, I want to chat a little bit about some of the just kind of like body composition changes that happen during these years as well, and how that feeds into this conversation. So generally, we see that when you go through menopause, you start to see maybe more issues with weight gain or with difficulty maintaining your weight. A lot of people think that it's just because of aging, but really it's because of the changes that are happening in part to aging, not necessarily aging itself. We know that really after the age of 30, you're starting to lose a few percentages of muscle mass every year. Just naturally, you're losing lean muscle tissue. And lean muscle tissue is not only what helps dispose of blood sugar, so it helps improve blood sugar control, but it also helps with metabolic control and metabolic rate. And so if you've gone through menopause, you're probably in your 50s, you've been losing muscle for 2 decades now. You can imagine how much less muscle you have at that point to help with metabolic rate. So actually your metabolic rate of how many calories you're burning at rest has been decreasing every year. And that's why things are starting to slowly, very slowly over time, start to become harder as it relates to keeping weight off and helping support body composition. So we really want to work against those natural changes of gravity by supporting our lean muscle mass. And the earlier we can start on this, the better, but it's never too late to start here. We really want to work on the lifestyle and nutritional things that we can do to help really support lean muscle. And I think a lot of women get worried at this time period about building muscle and about eating a diet that has adequate protein, but that's really what our focus should be. As you get older, your protein needs actually increase. A lot of people don't realize that. So the amount of dietary protein you should be consuming increases close to about almost a pound, a gram per pound body weight per day, which might sound pretty high. But, if you weigh 150 pounds, we might be looking at 130 grams of protein per day to support just keeping you in a state where you're not losing lean muscle mass. So protein and also the way that you distribute protein throughout the day, making sure that we're not just eating all 130 grams of that at dinner, but that we're really dividing it evenly throughout the course of the day. Optimally, about 4 times per day, you should be consuming an equal source of protein, because our body is consistently breaking down lean muscle tissue about every 3 to 5 hours throughout the day. So we want to be trying to get the body out of that breakdown state at every time period that that's happening. So, that might look like 30 grams of protein at breakfast, 30 at lunch, a 30-gram snack, and 30-gram dinner. That would be a really good way to get to that 130 grams of protein per day. Also, resistance training is really important here. Not only is it going to help the lean muscle tissue, it's also going to help prevent sarcopenia, which is something that occurs as you get older and you lose muscle mass and you become more frail. So this could look like anything that's really putting resistance on your muscle. It could be weights, it could be, bands, it could be a type of exercise machine, but really body weight and free weights are going to be the best for this because they also help support balance. But this is something that I would definitely, explore further with someone who specializes in this area for resistance training to make sure that you are getting adequate resistance training and that it's structured effectively to support lean muscle tissue. And then really just making sure that we're focusing on sleep. I know that that's something that gets harder in this period of time, but if we're not sleeping adequately, then we're not going to be able to build lean muscle mass or sustain lean muscle mass. And we're going to see more issues present with hunger hormones and blood sugar and everything else that we're talking about here. So whatever needs to be done to investigate why those sleep issues are happening in areas that we can support sleep is going to be a really big piece to supporting weight maintenance and potentially even weight loss if that's a goal of yours. So as I mentioned earlier, we're going to dive more into some of these nutritional treatment strategies in our next episode. This episode hopefully serves as a really good overview of what's happening in your body during this time period, why it's happening, and some starting places for areas that you can explore further. We talked about improving blood sugar control. We talked about really focusing on lean muscle tissue through resistance training and protein intake. Those are some great places to start. And now in our next episode, we'll dive deeper into some other types of nutritional treatment strategies.
Yes. And all of those things are things that we can cover in our one-on-one sessions. So I know, Lauren, that you had mentioned your plan, whether that's your exercise or your diet plan, it's not going to look the same as when you were 25. And that's all information that we can chat about. What plan makes the most sense for you? So contact the office if you're interested in booking a session with me. And I'd be more than happy to chat with you. But be sure to tune into our next episode, follow-up episode to this conversation in 2 weeks.
Thanks, everyone.
Thank you for joining us for today's episode of Nourish MD, Doctor Dietitian Dialogues. This podcast is intended for general educational purposes only. It is not a substitute for professional medical advice. Please consult with your healthcare provider before beginning any nutrition or supplement recommendations. Sign up for our mailing list so you'll never miss an episode of our wellness journey. See the podcast description for the link.